Okay, thank you so much. I am sharing my screen, am I not?
Oh, no, it's not showing up for
You
me.
are, no,
There you go.
no, there we go. Now you are.
There we go. Okay, thank you. So, quick introduction. My name is Denise Lewis. I am a nurse. I've been a nurse for 28 years. The majority of my clinical career was in the emergency room where I would take care of a lot of sepsis patients on the coming in side. I actually stepped into this role um, in March of this year. So really exciting to be in this role. And, I think one of the things hopefully we'll realize when everybody will know a little bit more about sepsis when we're done here, but just realize how pervasive of a problem sepsis is and how many lives it touches. So really with that, I think I'll just dive right into it. And the main question that a lot of people really don't know is what exactly is sepsis, right? And that was actually at the event on Saturday was a real great opportunity to really understand that that question is really out there. A lot of folks really thought that it is an infection in the blood, and that's not what it is. And come on, Paige, there it is. Okay. So first of all, sepsis is just a real bummer. Let's just start with that. It's estimated that there are 1.7 million adults in the US each year that contract some form of sepsis, and roughly 3,500,000 people die a year in the United States from that. It is the number one reason people die when they are in the hospital, and roughly 33 to 35% of people that are living with HIV and AIDS that are admitted to an ICU are coming in because of being in a sepsis state. So what sepsis is, it's really it can be a life-threatening condition, and it's more of a syndrome that is happening when your body is responding or trying to fight an infection, and you actually injure your own tissues and your own organs. Now, certainly there is sometimes a component of it where there is bacteria in the blood, but that is absolutely not always the case, okay? It's the organ dysfunction that's caused by a dysregulated host response to the infection. And when that end organ damage starts happening, it can affect a multitude of your organs, kidneys, your blood system, your clotting factors. It's just a whole cascade of events that can happen. And we call it a dysregulated host response because it's just not working the way that it should. It's also been described as being unbalanced or erratic, much like a woman, an independent woman in the 1800s, right before they were hauled off to the sanatorium. What are risk factors for developing a sepsis state? First and foremost, it's the very young and the very old. It affects newborn babies, neonates in the first 28 days quite a bit. And then once you're over 65, that's just a checkbox that you're automatically at risk for. Having a compromised immune system, whether that is because you have an HIV/AIDS diagnosis or a cancer diagnosis, or if you're on immunosuppressing medications for another condition, such as psoriasis or Crohn's disease. There's a lot of this whole new explosion of biologic medications that's out there nowadays. These are great, great medications that really improve quality of life. However, they do suppress the immune system. That's kind of how they work. And that puts you at an increased risk of getting an infection, which then leads to a sepsis event. Having multiple chronic illnesses, diabetes, high blood pressure, all of the usual cohorts, the more you have, the more at risk you are. And then also, if you have had a sepsis event in the past, if you get sick again with an infection, that leads you to be more likely to advance into sepsis again. So specific to the QIA community, I just wanted to bring this study, and this is, I don't think, going to be a news flat or really news to anybody, but it's one of the things that I think that we just need to be, as healthcare providers, more aware of. And anyway, so 1 in 6 persons that were surveyed of the 469 reported avoiding going in to see a provider because of anticipatory discriminatory behaviors from their provider. And then 75 of those 469 reported being actively discriminated against during their visit with their healthcare provider. And, one of the key points about not getting of sepsis is not getting it. And one of the ways we don't get it is early treatment and intervention for any infection. So this is really one of those things that, as a sepsis coordinator and somebody who wants to prevent it, that we need to work on as a healthcare community, as a society in general. And of course, overall discriminatory rates are much higher for racial and ethnic minorities than their counterparts in healthcare, and pretty much every place else. So this impacts what we call the social determinants of healthcare for the community. And it can affect, as you guys know, employment, the criminal, your involvement in the justice system, politics, and just making people more at risk for being disenfranchised in the healthcare system, and putting them in a poor baseline of health in the first place. And that's then a risk factor. Now, with people living with HIV, what we're seeing more is, thank goodness, people are not coming in into the hospital to get an HIV diagnosis. We're seeing more and more people coming in for the regular garden variety of reasons that we see the rest of the non-HIV AIDS population. Pneumonias, heart attacks, things that come along with the elderly, being CHF, congestive heart failure. So that's a really good thing as far as coming into the hospital. The most common reason that folks are coming in is because of sepsis. That accounted for 23% of the non-AIDS defining infections that people are being admitted with. The second most common reason is pneumonia. Whether it's a community acquired pneumonia or a hospital acquired pneumonia that they got from a previous hospitalization, and now they're coming back. The main thing with a bacterial pneumonia is that it's the #1 reason then that people develop sepsis. So that there's sepsis, and then there's pneumonia, which can then lead back up to sepsis. The third reason is cellulitis or skin abscesses, which cause that's an infection, which of course can then evolve into sepsis. So those are really the top 3 things that we're seeing in our HIV/AIDS patients in the ICU. So with sepsis, time is tissue. Basically, the longer you have an underlying infection that's not being treated appropriately, the more damaging it is to your tissues, okay? So, and sepsis is all about the underlying tissue damage and organ damage that's happening. And we want to prevent that as fast as, well, of course we want to prevent it. We want to head it off as quickly as we can. So time is equal to tissue. The Sepsis Alliance really put together this lovely diagram here that really TIME for the 4 main symptoms and signs that you can have if you are thinking that you have a sepsis event. And I broke them down over here. So the T is for temperature. That's really if you are having somebody, if you see somebody or you have somebody that has a temperature of 100.9, or actually a low temperature below, oops, excuse me here, I'm gonna move my mouse, below the 96.8 mark. That's what we call a hot sepsis or a cool sepsis. both of these are indicative of an inflammatory response, okay? The I being infection, we want to get on top of any infection that you're having, especially if it's a bacterial infection. You know, fever, chills, shortness of breath, boils with redness on the skin, dental abscesses, anything that can get infected, really, we want to keep an eye on. And you have to have an infection in order to have sepsis. The M on time is mental decline. So that can be confusion, being sleepy or lethargic, difficult to arouse, slurred speech, not acting quite right. I can't tell you how many patients have come into the emergency department, families, friends bringing them in because they think they're having a stroke with the slurred speech. And really, it's not a stroke, it's sepsis. So that's a real big one. That's kind of a, if I could put an asterisk by anyone and say, if you have slurred speech, you need to get evaluated. And then the E in the time is extremely ill. Somebody saying, I've just never felt this bad before. Feeling worse than what you think you should feel based on what you have. And if you have a couple of ant bites on your foot from walking out in the yard and the next day it's red and inflamed and you're running a fever and chills, I mean, that's pretty extreme for your ant bite. You want to get in for that. So those are the main TIME acronym that we're really going with in the sepsis community. And of course, the main thing is prevention. Stay healthy. As you know, the best defense against getting sepsis is not getting sick in the first place. So how do we do that? Got to wash our hands. I mean, this is such a basic thing that we all can do better at. I mean, there's a multitude of studies that show time and time again how just crucial washing your hands is. I mean, humans are just filthy germ factories, and we touch things and we rub our eyes, and even when you don't realize you're doing it, but wash your hands, wash your hands, wash your hands. Get your vaccines, your flu vaccine, your COVID vaccine, your pneumonia vaccine, your shingles vaccine. You know, these are there to keep you from getting sick, and also to minimize the degree of illness if you do actually end up getting something. So it is very important. The next thing is taking your medications. I cannot stress this enough. Medications cannot work if they are not getting inside your body. People, when they're getting discharged from the hospital, one of the key takeaways I emphasize with them is picking up that antibiotic prescription on the way home from the hospital. Don't wait. Don't go home and sit down on the couch and get comfy and think, oh, I'll go get it tomorrow, because then, you know what, people are more likely to not get it. So taking your medications so that they can help keep you well. And then the last thing is really getting into your doctor or your healthcare provider urgent care clinic if you do suspect that you have an infection that is making you feel worse than you should. Again, the sooner we can get you treated, the more likely we are to prevent you from getting sepsis in the first place. So that's really, that's my sepsis overview. I hope that helped really clear up any questions or answer maybe more what sepsis is. So I will now stop sharing and open up for questions.
Great. We'll open up for questions of anyone online, but we also have a couple of questions in the chat. Is a couple of ones. The first one is sepsis, is sepsis contagious? It's a lot of S's.
Sepsis is not contagious. Thank you for asking that. The underlying infection that causes you to get into a septic state may be contagious. Like if you have influenza, right? if some things are. So influenza, COVID, you can certainly have sepsis from a viral infection, and viruses are really the most contagious. The coughings and the sneezings, those kind of things that we can spread to each other. Some pneumonia, for example, pneumonia is not contagious. So in and of itself, sepsis is not contagious.
Okay, thank you.
Mhm.
What is the difference between sepsis and septic shock?
Oh, that is a really great question. So sepsis is also a continuum, right? So if you think of like something that is like light sepsis, you're having just a light systemic inflammatory response, right? You have a little elevated fever, a little high heart rate. That's just a light little inflammatory response we always expect when we're sick. And then when we start going into what we call more of a severe sepsis state, where we're starting to see some elevations in your kidney function. So maybe your kidneys are starting to not work as good as we think they should, or you're getting a little confused. Well, as things continue to progress, you can roll up into the worst kind of state, which is a septic shock state. And that is when you are at the point where your body or your system, you can't maintain your blood pressure. Okay. And so that's one of the reasons that we do a lot of aggressive fluid resuscitation at that time. That's why time to antibiotic is so critical, because once you're in that shock state, it's really a lot like any of the other shock states. It's sort of the most extreme case of organ failure. It's where you've got multiple systems that are failing, not just one or two.
Thank you. How large of a problem is sepsis of number of cases that Eisenhower sees or current, do you think, or in the marketplace, I guess?
Well, so on a monthly basis, I run reports on this, so I'm glad that you asked that. So we see about 260 patients, somewhere between 200 and 260 patients a month are admitted with sepsis as a primary diagnosis or as a secondary admission diagnosis. And from there, we usually admit, I would say about 20 to 25 patients a month to the ICU.
All right, thank you.
Mhm.
How will I know if I had sepsis, how would I know if it returns? Is that just a,
Oh, great question. So how do you diagnose sepsis, or how do you know? Well,
yeah,
that's one of the problems with sepsis, is that there's no easy peasy test you can't just, swab something and have it say, yes, no, you have sepsis. It doesn't work like that, because there's so many different organ systems that can be involved. And there's so many sources that an infection can come from. We don't have one marker that tells us, aha, this is sepsis. We look at a blood count, we look at your chemistry panel, we look at your blood pressure, we look at your mental status, how is the blood flow in your tissues. We have to look at the overall picture of it. And once you start meeting certain criteria, then we know that you have sepsis, right? So it's not like you can't do some tests you can do antibody tests for. We can say, oh, it looks like you had hepatitis at some point in your past, but you don't have an active infection now. Not so with the sepsis. Now, there's a lot of exciting things. A lot of companies are working on trying to get tests that will better identify it, or come up with a panel of tests that, if you do these 3 tests and they score like this, it would be aha. So there's a lot of research that's going into this, because the company that can find this is going to make a ton of money. I mean, they are going to save a ton of lives, and they're going to make a ton of money. But and hopefully that comes sooner rather than later. There's a lot of, we're getting, part of the problem is we do blood cultures on people, right? When you come in, and that's to identify if there is bacteria that's actually in your bloodstream, which you don't always have. but those cultures, even when there is bacteria in your blood, to get a preliminary identification on that right now, it takes about 12 to 18 hours. So there is a company that has developed a test that will identify the bacteria, about like 5 bacteria types in under 5 hours. So that's really, that's getting better. But you can see why it's so hard to treat. And so for every hour that we delay getting you on the right antibiotics, it increases the chance of dying from sepsis by about 4 to 8%.
All right, thank you.
Sorry, that might have been a little
Yeah,
much.
that's good. And what type of specialists treat sepsis? How does that work within our medical world?
Oh, okay. So when somebody is admitted you first come into the emergency room, obviously it's going to be the ER physicians. They're going to do the blood, they're going to do the workup. And we have a 3-hour bundle really that we're trying to do from the time that we recognize that, okay, this is a severe sepsis case. We're seeing the end organ damage. Your blood pressure is not maintaining like it should. So we want to get you fluids. We want to get your antibiotics and your labs done right away. And then within 6 hours, if you're not really turning the corner, we want to make sure that we've got you on, they're called vasopressors to help support your blood pressure and keep your tissues getting perfused, right? And that we've repeated some of these biomarkers that we use. So door to antibiotic time is really important. And then depending on the degree of your illness, I mean, if you're admitted to the hospital, you're going to be, there's the regular hospitalist team that sees, or your regular doctor sees you in the hospital. If you're in the ICU, then we have a separate critical care intensivist team that sees you. We have infectious disease doctors that see you depending on what the causative organism is, to try to make sure that you're on what we call targeted antibiotic therapy. When people first come in during that time where we're waiting for those blood cultures to come back, or to have something like jump out at us, like this is the causative organism here, we do it's kind of a kitchen sink approach. We throw a couple different, what we call empiric antibiotics at you. And then once we know what's causing your illness, then we could move to the targeted antibiotic, right? So door to antibiotic time is huge, but also getting you on the right antibiotic. So infectious disease helps us guide that therapy if needed, if there's a question about what to do. I mean, we also, there's physical therapy, occupational therapy. I mean, because sepsis affects, every organ and all of your systems, it knocks you out. It makes you weaker than normal. So there's physical therapy to get you up and moving. There's occupational therapy. Sometimes we need to have speech therapy get involved, because it can affect your ability to swallow. It can make all of these underlying conditions that you have worse. So it just really, you might need to see the cardiologist. So really kidneys are a big one that gets affected. So if somebody comes in and they have new onset of kidney failure, if it's really severe, we're going to get a nephrologist in to see them as well. So it really, there's a whole slew of all the specialties could be involved. So it just kind of depends on if it's if you're on this end of the spectrum and it can be managed well with the hospitalist team, then that's great. They're very experienced in that. But like the more complicated, the more people you get involved on your team.
All right, thank you.
Uh-huh.
Do we have any questions from the audience? Anyone else? Because I have another last question, but it'll be appropriate for the final question, maybe.
Okay.
Because it's kind of funny.
Denise got a girl.
Oh yeah.
Good job.
Well, and we have a question. There's a couple of people that want to borrow your necklace or steal your necklace, so we just want to know where you got it.
Oh, where I got my necklace. Oh, listen to this. I got this at the Mitzel Center on Saturday when I was there with the Living Positively event with you. Yeah. And representing Eisenhower. That resale store was just fantastic.
Mizell Senior Center, the best place around. All right. Anybody have any other questions that would like to ask anything? Anyone? Anyone?
Esther, you've been very quiet and listening very intently. And so I hope we covered everything that was on your mind. But if you have any questions, feel free to jump in there.
Maybe not.
Esther's good.
Okay.
Esther's good.
Okay. Well, we appreciate the time and great topic. And then, as I said, you were on KGA this morning. You were on all kinds of different stuff. So, I know it's a
Yes.
lot of fast and furious getting it out there and getting the awareness out there for Sepsis Awareness Month. But we
Well, and
appreciate
thank
that.
you guys so much for letting me come here and speak on this. I'm very passionate about sepsis awareness. I think that people don't realize, I mean, it touches so many lives, not
Yeah.
just the person that has sepsis, obviously, but also the family members and the loved ones of the person that's affected, whether that's during the acute period in the hospitalization, but also after discharge, because recovering from sepsis takes longer than what we
Yeah.
than what we thought. And, with COVID, it really brought out, these post hospitalization, long COVID. Well, they're really finding out that there's some of this like long-term issues, depression, nightmares, some things that the longer you're in the hospital, the more prone you are to having those. And so this also affecting the people that have other conditions, sepsis being one of them. So I think it's so important to get the conversation out and make sure that when somebody is recovering, if they're suffering from depression, or, it's taking them longer than what they think they should, that we're also recognizing that so that we can get them into the right follow-up situation as well. Post-hospitalization follow-ups, just as important as inpatient follow-up, so that we don't have you come back in, for another hospitalization because you're not thriving outside.
Correct. No, and it's funny. I thought you and I talked about this on Saturday, but it was eye-opening to me. I assumed incorrectly, but I assumed sepsis was always. I always hear it about somebody who's physically in the hospital and physically has been there for a while, and a lot of that was due to COVID and other times where they're in there for lengthy stays, and then they acquired sepsis, and I just made the assumption that it was part and parcel, not something potentially external or outside or post or any combination.
Yeah, in fact, there's a study that says basically 80% of people are coming into the hospital in a septic state.
Yeah.
So
yeah.
it's really more of a community issue, coming in. And I tell, our new nurses and our new resident physicians that if somebody comes into the hospital and they're not septic when they come in, they might be very soon, because it is such a pervasive problem. And if you're not on the right antibiotic for whatever reason, it can be there. It's the great wingman, right? It's kind of the boogeyman. It's everywhere, because like I said, it mimics strokes, again. So we go down a path thinking somebody's having a stroke, and I don't want to say we're wasting time, but it's a time delay until we rule out that stroke. And then we go, oh, it's sepsis.
Yeah.
It's different problem. So
yeah. That's amazing. All right.